So first, we must say that all these videos from the Meet the Expert sessions will be uploaded very soon in the WPA website, and they will be accessible for everybody. And for today, our first speaker is Professor Raymond Lam, who is professor and leadership chair in depression research in the Faculty of Medicine at University of British Columbia, and associate head for graduate and undergraduate education for the UBC Department of Psychiatry. Dr. Lam is also director of the Mood Disorders Center at the Javad Mohavasyan Center of Brain Health in Vancouver. His research examines clinical and biological factors of seasonal, treatment-resistant, and workplace depression, biomarkers, clinical trials, clinical guidelines, digital technologies, and global mental health. Dr. Lam is also a lead investigator for the Canadian Biomarker Integration Network in depression and executive chair of the Asia Pacific Economic Cooperation Digital Hub for Mental Health. It is hosted at the UBC. His research is supported by many sponsors, including the Canadian Institutes of Health Research. Dr. Lam has received many awards for his research and teaching. For example, the J.M. Clarkson Award for Clinical Research of the Canadian Psychiatric Association in 2015, a Distinguished Achievement Award for Overall Excellency, UBC Faculty of Medicine 2014, the Silver Anniversary Leadership Award of the UBC Medical Alumni 2006, and the inaugural Douglas Utting Prize and Medal for Depression Research in 2001. Professor Lam will, as I said, is our first speaker and will talk about the measuring and the treatment of cognitive deficits in depression. Raymond, it's both a pleasure and an honor to have you with us. The floor is yours.
Well, thank you very much, Professor Falkai, for that lovely introduction, and to Professor Morozov as well for inviting me for this presentation. It's truly a pleasure and honor to be here. So I'm talking about a very important clinical issue in our management of patients with depression, namely cognitive deficits. And we're going to focus on cognitive deficits, and in particular, their effect on functional impairment in depression. And I'm going to show some data from our Canadian Biomarker Integration Network looking at those issues. This is just my disclosure statement and the sources of some of my funding, also available at my website, drraymondlam.ca. But obviously, depression is a global medical problem, and no matter what region of the world, depression is a very common condition. The World Health Organization estimates that over 322 million people suffer with depression worldwide, which really represents an 18% increase in the 10 years between 2005 and 2015. And depression is a very impairing condition in terms of functioning. And so if we look at a metric of years lived with disability, depression is or will soon be the #1 leading medical cause of years lived with disability. And that's estimated at the equivalent of 54 million years of lives lost because of disability. And of course, given the worldwide pandemic, we know that this is likely going to get worse, that more people, that depression is increasing with the results of the pandemic and the pandemic restrictions. And so it's very important that we look at treating depression and really trying to optimize our treatment of depression. Because even though we have many treatments, unfortunately, they're still variably effective. One way to improve treatment, of course, is to use clinical guidelines. And I've been fortunate to be a co-editor of our Canadian Network for Mood and Anxiety Treatments, CANMAT Depression Guidelines, that we published in 2016 as a theme issue in the Canadian Journal of Psychiatry, really giving recommendations, evidence-based recommendations for all of the treatments that we have for depression. We also recognize that busy clinicians may not have time to read the full issue. And so we've actually developed a pocket guide, which summarizes succinctly the recommendations given. But we've also developed a patient guide to the guidelines that was written by patients for patients and families so that they can learn about the recommended treatments for depression. And again, this patient guideline, as well as the full guidelines, are available at our website, canmat.org. But in our CANMAT guidelines, we focus on recovery in major depressive disorder. And our concept of recovery has changed over the years. Initially, we considered syndromal recovery, when people were treated and then improved and no longer met syndromal criteria for a major depressive episode. This is kind of equivalent to what we mean by clinical response, 50% improvement in a depression rating scale, for example. But we recognize that syndromal recovery really isn't good enough, because if patients are not in symptomatic recovery, if they're not in symptom remission, we know their outcomes are poorer, higher chance of relapse, poorer functioning. And so then the target became symptom remission as an important aspect of recovery. But for our patients, they regard functional recovery as more important than symptom recovery. And so now the target of treatment for depression really is ensuring that our patients recover their functioning to baseline, because that's what's important to patients. And we know that there are many things that can interfere with functional recovery. That includes things like chronic, recurrent, and severe episodes of depression, depressions that's difficult to treat if it's taken a long time to get them feeling better. Comorbidity can interfere with functional recovery, whether that's psychiatric or medical comorbidity, and the presence of residual symptoms. And in particular, there are some residual symptoms like cognitive problems that are even more important in terms of impairing functional recovery. And we'll talk about that. But we also recognize that depression, of course, has many different types of symptoms. There are emotional symptoms, including the mood and anxiety experienced by patients with depression. There are physical symptoms like sleep and appetite problems. And then there are cognitive symptoms, some of the concentration, memory problems, feelings of guilt and self-blame, hopelessness, and suicidal thoughts. You know, when we talk about severity of depression, we often consider all symptoms of depression as kind of equally important. But in fact, now it seems there's more and more evidence that some symptoms are more important than others when it comes to their impact on functioning. And we recognize that because of studies like this one. This is from data from the large US STAR-D study, the large effectiveness study, where they looked at over 3,700 people with depression. And they looked at specific symptoms based on a symptom scale. In this case, it was the Quick Inventory of Depressive Symptomatology, self-rated. And they looked at the impact of individual symptoms on functioning as evaluated, assessed by the Work and Social Adjustment Scale. And what they found was that not all symptoms interfered with functioning with the same impact. And in fact, 3 symptoms, sad mood, concentration, and fatigue, were the only ones that were significantly associated with functional impairment on the Work and Social Adjustment Scale. The others were not significantly associated with functional impairment. So I think this shows the importance of some of these symptoms, particularly cognitive symptoms like concentration, alongside of fatigue and sad mood, as being particularly important for functional impairment. In fact, across all the domains of work and of the Work and Social Adjustment Scale, work, social life, family life, only concentration and fatigue actually predicted functional impairment across all the domains. So again, showing the importance of cognitive symptoms in terms of its effect on daily functioning. Well, if cognitive dysfunction is so important in depression, how do we assess cognitive dysfunction? Well, we can assess it with neuropsychological testing and with self-report measures or questionnaires. Of course, neuropsychological testing is really kind of the gold standard objective test of cognitive functioning. The problem, though, with neuropsychological testing, of course, is that it's not very accessible for routine clinical care. It takes usually several hours to do, very specialized training, really not practical for routine clinical use. The other issue with neuropsychological testing is that it gives you a snapshot, a point in time assessment of cognitive functioning. And it's usually done in a stress-free environment where people are, a quiet environment where you can really get what might be considered optimal cognitive functioning. So that's why for busy clinical settings, self-report measures may be more practical and more feasible to use in terms of assessing cognitive dysfunction. And there are many scales that we'll talk about that can be used to get a quick assessment of some of the cognitive complaints and problems that patients are having. However, the problem is that many studies have shown that subjective cognitive measures have no correlation with objective measures of neuropsychological functioning. And so they seem to measure different things. And if we think about it, the self-report measures may be more applicable to real life, because when people are self-assessing their cognition, they're thinking about their cognitive problems in many different types of situations, whether that's at work or at home, during stressful times, during not stressful times. So it may be a little bit more indicative of real life functioning than the point in time measure of neuropsychological testing. But realistically, it would be very helpful to have both objective and subjective assessment of cognition. So I'm going to talk a little bit about some data from our Canadian Biomarker Integration Network in Depression, CANBINE, which has been running now for about 10 years in Canada. And the objective is to integrate imaging, clinical, and molecular markers to identify predictors of treatment response. Not only medications, but also psychotherapy, neuromodulation treatments across this broad range of interventions. And in CANBINE, we've developed integrated platforms, standardized assessments that can be done through different centers and through different, for example, imaging machines, so that we can pool data together and be able to increase the sample size that way. And you'll see we have these standardized integrated platforms for a variety of assessments. But we particularly wanted to look at practical, pragmatic predictors of treatment response. So we didn't really believe that everyone will have a fMRI prior to starting on an antidepressant medication. And that's why we included things that are more feasible for routine clinical practice, like EEG, in terms of our assessments. Now, we had a nice discussion earlier talking about the challenges of diagnoses. And so for our clinical assessments, we really took a pragmatic and agnostic direction in terms of our assessments. So we used traditional scales of depression, including the Montgomery-Åsberg Depression Rating Scale, widely used to measure treatment response. But we also were very interested in dimensional scales. So outside of our classification systems, more in terms of the research domain criteria, for example, in the US, we use dimensional scales to measure a number of dimensions, including things like reward, anhedonia, circadian rhythmicity, exercise, childhood maltreatment, which we'll talk more about, pain, for example, because we recognize that there are many different aspects to depression that may not just be represented by the 9 symptom criteria in DSM-5. And of course, when we started out, relatively novel, not any longer, we used integrated bioinformatics and data science using machine learning and artificial intelligence techniques to integrate all of these measures in terms of treatment response. So just to kind of talk about our first study, which was a treatment study looking at predictors of antidepressant treatment. And so very simple study, again, pragmatic study where we screen people and admitted people who had major depressive episodes. And we treated them with escitalopram, SSRI, widely used medication, 10 to 20 milligrams for 8 weeks. And at the end of 8 weeks, the responders, people who had improved by 50% or more on the Montgomery-Åsberg Depression Rating Scale, we continued them on escitalopram for another 8 weeks, 16 weeks in total. For the non-responders at 8 weeks, we added aripiprazole 2 to 10 milligrams for 8 weeks to the escitalopram. So they had augmentation treatment with this atypical antipsychotic. So this was a 16-week study, open label, no placebo, and we examined all of our markers, potential predictors, at several time points through the protocol. Now, when we looked at cognition, we used a simple computerized cognitive battery called the CNS Vital Signs battery. And again, we were pragmatic. We wanted something that could potentially be used in clinical practice. So this particular computerized battery takes only about 20 or 25 minutes to do. And it consists of 7 tests of looking at that assess the important domains of cognition, and gives you an overall global score called the Neurocognitive Index that is an overall measure of cognitive functioning. And what we found, for example, in the first 8 weeks, when we, at baseline, when we compared the 200 patients that we examined in this study compared to about 112 healthy control, that you can see that for the overall neurocognitive index, again, the higher the score, the better is the cognition. You can see there was a significant deficit in the patients, a significantly lower cognitive index compared to the healthy comparison patients. And really across all of the dimensions assessed in our cognitive battery, the patients had poorer cognition. This was statistically significant for composite memory and for psychomotor speed. So this is not new data. Many studies, many meta-analyses have shown that depressed patients have cognitive deficits that can be demonstrated with cognitive testing. But we were particularly interested in some of the functional impairment associated with cognition. And again, when we look at the key domains of cognition, and all of these domains can be impaired in people with cognition, with depression, it's no surprise that it leads to significant impairment in daily functioning, particularly problems with executive functioning, problems with planning, organization, multitasking. And so in our Kanban study, we assessed functioning using a simple scale, the Sheehan Disability Scale, widely used in depression treatment studies. Only 3 items asking for interference of functioning in work or school functioning, social life functioning, or family and home responsibilities functioning. So again, the higher the scores on the scale, the greater is the functional impairment. And so when we looked at baseline results in terms of the cognitive deficits that patients had, and these are the same data that I showed before, but now these are the differences, the deficits compared to healthy control populations, where the farther down the bar goes, the greater is the deficit compared to healthy controls. We looked at the association with functional impairment, and we found that there were two predictors of functional impairment in these cognitive domains: composite memory and psychomotor speed. And so those were predictors of particularly the work and study item on the Sheehan Disability Scale. And these were predictors independent of the severity of the depression, again, showing how important some of these cognitive domains are in terms of their effect on patients' functioning. Of course, when we're talking about cognitive dysfunction in depression, we have to think about other potential reasons for cognitive dysfunction. And so there's a differential diagnosis or a contributing factor that might relate to, for example, age-associated cognitive decline in older patients, the differentiation between with mild cognitive impairment. Of course, we always have to rule out the beginning of a dementing disorder like Alzheimer's. But we also know that sleep disorders and brain trauma can cause cognitive problems. And in particular, medical conditions like obesity and diabetes also associated with cognitive impairment independent of depression. And of course, we have to remember that many of our psychotropic medications can have cognitive side effects, particularly those with anticholinergic effects. And then that patients, of course, can be using and misusing substances, which can also contribute to cognitive dysfunction. But more and more, we're also recognizing that an important factor is childhood maltreatment or abuse. We know that child maltreatment is associated with increased rates of depression in adulthood, and also can be associated with cognitive deficits by itself. And so for our CANBIND study, we're very interested in doing a very comprehensive assessment of childhood maltreatment. And so we, instead of using a questionnaire, we used a semi-structured interview, the Childhood Experience of Care and Abuse interview. And this is done by trained raters using a semi-structured interview. It's a well-validated interview that seems to provide more accurate information than a simple questionnaire. The experiences are rated on what are more objective behaviors and experiences. And then there are subcategories with this interview looking at emotional, physical, and sexual abuse. There's a severity scale associated with these domains, and ranging from none through to moderate or marked severity of the particular type of childhood maltreatment. And so for our purposes, we defined maltreatment in childhood as moderate or marked experience in any of the three subcategories. So we examined the presence of childhood maltreatment in the healthy controls and the patients in our CANBIND-1 study. And so we came up with these four categories. For the healthy controls, the majority, 80 of the 102 patients, had no history of childhood maltreatment. About 20% did have a history of maltreatment. Whereas for the depressed patients, it was about 50-50. About half the patients with depression had no history of maltreatment. The other half did have a history of childhood maltreatment. So again, the association of maltreatment with depression is significant there compared to the healthy control populations. But we have these four categories now: depressed patients with and without maltreatment, healthy controls with and without maltreatment. And so we looked at the cognitive functioning of these patients associated with these particular categories. And we found some interesting results. So when we looked at the 4 categories, it turns out that only the depressed patients with a history of childhood maltreatment seem to have clear cognitive deficits compared to the healthy control individuals. Then in fact, the patients that did not have childhood maltreatment were much closer and not statistically different from the healthy control sample. And this was true looking at the global cognitive score, the neurocognitive index. It was true for composite memory and also for processing speed. So, this is very interesting because it appears that it was the presence of childhood maltreatment that seems to be more related to the cognitive deficits found in depression than the actual diagnosis, because the depressed patients without maltreatment seem to have relatively preserved cognitive functioning. So this illustrates the importance of childhood maltreatment in our patients with depression. We also looked at post-treatment in the patients who were remitted from depression. In other words, their scores after 16 weeks were in the normal range in the MADRS, 10 or less. And what we found was that, again, the cognition improved in working memory and processing speed from baseline through to week 16 in all the patients. However, by the end of treatment in these remitted patients who were no longer depressed, only the patients who had a history of childhood maltreatment continued to have cognitive deficits relative to the healthy controls. And the patients without a history of maltreatment, again, not statistically significant from the healthy controls. So again, we recognize that some patients do have cognitive deficits even in remission after treatment, but it appears that it's the presence of childhood maltreatment that may mediate that association. Now, we also looked at hippocampal volume, of course, very important in terms of looking at cognition. And there, we did not find any significant differences between the depressed group and the healthy control group in terms of the hippocampal volumes, which goes against some of the positive findings in other studies. However, when we grouped the healthy controls and the patients together, again, what we found was this association with childhood maltreatment. That in the people who had a history of childhood maltreatment, the hippocampal volume was lower than in those that did not have a history of maltreatment in both left and right hippocampus, and primarily in those who had a history of childhood sexual abuse. So again, this was independent of the diagnosis. This was just in the total group, both healthy and depressed patients, where it was really the history of childhood maltreatment that seemed to be associated with lower hippocampal volumes. So I think, again, just to summarize in terms of those findings, which I think are very important in terms of our understanding of cognitive deficits in depression, that childhood maltreatment was significantly associated with with cognitive dysfunction in both acute and in remitted adults with depression. That especially childhood sexual abuse is associated with smaller hippocampal volume, whether or not people were clinically depressed. And that we really should be looking carefully at maltreatment history in future studies of cognition in depression because of this, what seems like a strong association between maltreatment. And as clinicians, we should be alerted in our patients with a history of childhood maltreatment that they are at higher risk of having cognitive deficits both while they're depressed and perhaps even after their other symptoms have gotten better. Okay. So that's looking at some of the neuropsychological findings in depression. But of course, even with our relatively simple battery, 20 to 25 minutes is probably too long of a test to use routinely in busy clinical practices. And so I was fortunate to be part of an international group called THINK, which looked at cognition in depression. And along with the lead investigator, Professor Roger McIntyre from Toronto, we developed a very simple cognitive screener called ThinkIt that involves only 4 simple tests: digit symbol substitution test, choice reaction time, trail making B test, and a 1-back memory task. And this is these tests are actually done on a tablet device like an iPad or an Android tablet. Each of these tests actually takes under 2 minutes. So the entire screening battery can be done under 15 minutes and can be completed by the patient themselves. And so this is a very simple and feasible cognitive test that you can use in your clinical practice. And it's available for free download at the think.progress.im website. So please have a look at that. We validated the ThinkIt study in a sample of patients with depression and found that almost half performed 1 standard deviation or more below the mean for healthy control individuals. So it did seem to identify cognitive problems in depression. And particularly important in clinical care, it seems sensitive to change with treatment. So you can use it to determine if patients are improving and back to hopefully baseline in terms of their cognitive functioning with treatment. Okay, well, what about self-report measures? Because we said that these are also very more feasible to use in a busy clinical practice. Well, several cognitive questionnaires have been validated specifically in depression. And I've been fortunate to have been involved in 2 of these validations. One is with neuropsychologist Grant Iverson, the British Columbia Cognitive Complaints Inventory, a very simple questionnaire, only 6 items, and validated in a sample of patients with depression and healthy controls, as well as the Perceived Deficits questionnaire, specifically for depression, that was modified from one developed for multiple sclerosis, but has 20 items in the main questionnaire, but a simpler 5-item version is also available, again, validated in a large number of people with depression and healthy controls. Maurizio Fava also has one, the Cognitive and Physical Functioning Questionnaire developed at the Massachusetts General Hospital. Again, 7 items. This scale also looks at cognition as well as motivation, alertness, and energy. Certainly the BCCCI and the PDQ can be found at my website, raymondlam.ca, and available for clinical use. This is just to show the PDQ-5, very simple 5 items, very easy to rate, takes less than 2 minutes or less to complete. You add up the scores. The higher the score, the greater are the number of cognitive complaints and cognitive problems that a patient is subjectively experiencing. This really just shows the association of a cognitive measure like the PDQ-5. Along here is the total score. Again, as the score increases, you have more cognitive complaints in people with depression. And along the y-axis is the Sheehan Disability Scale Functional Impairment Score. Again, the higher the score, the greater is the functional impairment. And this just shows the nice relationship between the cognitive score. As cognitive dysfunction increases, the functional impairment also increases. And again, this relationship seems independent of the severity of depression. So both cognitive dysfunction and depression severity were both independently predictors of functional impairment. Well, what about treatments? Because we have a lot of different types of treatments for major depressive disorder. And now we're starting to recognize that some treatments may be better for the cognitive deficits than others. And that's important when we're looking at treatments. I'm going to tell you a little bit about a very simple cognitive test called the digit symbol substitution test. Widely used test of processing speed, global cognition, takes only a couple of minutes to do. And what you do is you have a look at the numbers here and the associated symbols, and you simply put down the symbol that's associated with the proper number. So 2, you put in this symbol here. For 1, you put in this symbol here, et cetera, et cetera. Get a bit of practice, and then you try to do as many symbols, complete as many symbols as you can in 90 seconds. So this is a wonderful global test because it assesses attention. You need to be attentive to do this test. It measures psychomotor speed because it's timed, and it measures executive functioning because you have to go back and forth between the table and completing the symbols here. So it's widely used, probably the most widely used test of cognitive functioning in the literature. And it's well known that people with depression do poorly on the DSST compared to control subjects. Well, my colleague Bernhard Bahn in Germany conducted a network meta-analysis looking at all of the studies of antidepressant treatment, assessing cognitive change as assessed by the digit symbol substitution test. And there they found a very interesting findings. This is the effect size, the difference, the improvement in the DSST following treatment in depressed patients. The higher the bar, the greater is the improvement in the DSST. The lower the bar, the greater is the worsening on the DSST following treatment. And you can see that some medications like MAOIs and tricyclic antidepressants are actually associated with worsening on this cognitive test. And that may be because of the anticholinergic properties, which we know impair cognitive functioning. But here you can see that SSRIs were fairly neutral in their effect, not statistically significant in this cognitive test, whereas SNRIs did seem to show positive benefit following treatment, although this was not statistically significant in this network meta-analysis. Only vortioxetine, the multimodal antidepressant, showed clear improvement in cognition following treatment as assessed by the DSST. And this just shows the individual antidepressants that were assessed in this network meta-analysis. So I think this is some of the evidence which now suggests that some medications may be better for the cognitive deficit seen in depression than others, and in particular vortioxetine and possibly the SNRI medications. In terms of looking at vortioxetine, this study, this is actually a Canadian study done by a colleague of mine, Pratap Choka, where they looked at open label treatment with vortioxetine, 10 to 20 milligrams over a year's time in people who are actually working and depressed. And what they found in this group of almost 200 patients was a clear association between the subjective cognitive complaints that patients had and the change in their work functioning as assessed by the work limitations questionnaire. So that the greater the improvement in terms of their subjective cognition, the greater was their improvement in work functioning. And this was, again, independent of the improvement in disease severity as measured by the QIDS-SR symptom scale. So again, I think showing the importance of making sure that cognitive improvement occurs in terms of its effect on functioning. We also looked at, now this was a subjective scale of cognition. And so we also looked at the relationship between neuropsychological testing and occupational functioning in employed patients who are being treated for depression. And we did, again, a simple study where we took about 40 patients with depression who were still working either part-time or full-time while they were depressed and while they were being treated for depression. And we treated them with desvenlafaxine and SNRI antidepressant 50 to 100 milligrams over the course of 8 weeks. And we tested them before and after treatment using the CNS vital signs computerized test battery. We also looked at assessments of occupational functioning as well as symptom measures, and then cognitive functioning as well, again, using the CNS vital signs computerized battery. And what we found was, again, not surprising, that patients improved from baseline here in the gray. They improved following treatment in purple on all measures of the cognitive test battery, whether it was the global neurocognitive index or on every domain of cognition assessed by the CNS vital signs computerized battery. Again, no surprise there. Many studies have shown that antidepressants improve cognition, particularly SNRI antidepressants. But we were interested in whether improvement in cognition led to greater improvement in functioning. And because this was an open study with no placebo control, we decided to only look at the people who had substantial benefit in cognition. And we defined that as people who improved on the neurocognitive index by at least 1 standard deviation of the mean. Most people would agree that that is a clear improvement in cognition. And what we found was that in the patients who improved who showed clear improvement in cognition, and that was about 1/3 of the patients in our group of 36 patients, that they had, of course, by definition, they had improvement in their cognition, but also they had more benefit on symptom scales like the MADRS and the subjective QIDS-SR. Compared to the people who did not have that degree of cognitive improvement. We also found that the people who had that degree of cognitive improvement had greater improvement in work functioning, as assessed by our LEAPS work questionnaire and by the health and work performance questionnaire, the gold standard questionnaire looking at work productivity. And so what this shows is that improvement in cognition leads to greater improvement in functioning. And again, showing that importance of cognition to functioning and why we should really make sure that our patients improve in cognition to ensure that they have optimal functional recovery. That's why in our CANMAT depression guidelines, we actually focus on clinical dimensions that might be important in terms of treatment selection. And we identified cognitive dysfunction as one of those clinical dimensions, more important than some of the subtypes like melancholic or atypical depression. And here, when we summarized the evidence, we found, again, there was good evidence that vortioxetine may be a little better than other antidepressants in terms of that addressing cognitive dysfunction. We found second level 2 evidence that SNRIs like duloxetine, NRIs like bupropion, and possibly SSRIs, but again, these were studies only looking at comparisons against placebo and not necessarily head-to-head comparisons as seen with these other medications. And there was less lower quality evidence that meclobamide may be helpful as well. So again, when we're looking at treating cognitive dysfunction in depression, we may want to look at using medications like vortioxetine and SNRI or NRI antidepressants. So just to summarize what we've talked about over the course of this talk, depressive symptoms cause significant impairment in functioning, which is why depression is so important to the individual and to society. That cognitive dysfunction is a major mediator of functional impairment in our patients. And that in particular, childhood maltreatment may be a very important mediator of some of the cognitive deficits that we see in depression. And that's why monitoring cognitive symptoms is so important during our treatment, making sure that our patients can optimize their functional recovery by making sure they don't have residual cognitive deficits, even if other symptoms of depression improve. Thank you very much.
Thank you, Raymond, for your very important talk. You covered the whole field in a very thorough way. We have two questions, but first, let me exert the privilege of the host and ask you: do we have any idea how childhood maltreatment mediates? What's the mechanism through which childhood abuse mediates cognitive impairment in later life?
We have certainly a lot of hypotheses, and probably the main hypothesis is through impaired immune functioning, through disturbances in cortisol at the HPA axis level. Certainly emerging studies now showing the impact of particularly chronic stressors on immune functioning and neuroimmune functioning, and of course the impact of cortisol on things like hippocampal atrophy. And so I think that's one of the key hypotheses for the mediating effect of childhood maltreatment, as perhaps even a scar effect, where childhood maltreatment leads to increased cortisol, which leads to hippocampal atrophy, decreased volume loss or increased volume loss, and cognitive deficits, which then are magnified when people become depressed.
So we have two questions. Are the cognitive deficits that are related to depression irreversible when depression is treated? I think you more or less answered that, but
yeah. So that's a very good question, and it's probably a more complex question than than we think, because again, generally speaking, people's cognition improves with improvement of the depression. But we now know many studies show that there are still cognitive deficits that can be demonstrated in groups of people, even in remission, like our study showed. What's not clear is the reason for that cognitive deficit. Was it pre-existing cognitive deficit before they were treated, for example? Is it related to a scar effect like childhood maltreatment, in people with depression? And so I think that's where we're at right now. We need to do more longitudinal studies at baseline and following, treatment to really determine who has cognitive deficits and what, whether those are remediable with treatment. Of course, with this talk, I only talked about antidepressant treatment, but we know there are other treatments focused on cognitive dysfunction. For example, cognitive remediation is a well-established psychological treatment that focuses to be helpful in people with schizophrenia, and now emerging evidence that it's also helpful in people with depression. So we may be able to target some of the cognitive dysfunction using different types of treatment.
And the second question is how to differentiate between cognitive dysfunction of mild cognitive impairment and early phase of dementia versus early onset dementia and cognitive deficit seen in depressive elderly people. Well, that's that's a bit tricky.
And
On the other hand,
if
can
I
we
had the
speculate
answer to that, I'd win the Nobel Prize. So
on the other hand, can we speculate that early childhood traumatization is risk factor for cognitive dysfunction, not just in depression, but also in dementia?
I think that's a good question, and you know, I'm not sure about the literature on that. That's actually a very good question as to whether that might be a factor in terms of dementia. Of course, there are no good tests that can easily differentiate between depression, MCI, and Alzheimer's. You know, it's really, you know, kind of following patients, making sure you treat what is treatable. And, you know, again, the importance, though, of monitoring cognition through any treatment.
Peter, it's your turn.
So thank you very much. Very kind of you. First of all, thank you,
I
Raymond.
was
Oh.
I was addressing Peter
Oh,
Morozov
addressing,
to introduce
having
you.
a question. Okay.
Yes, Peter Falkai, they will introduce you.
If you have a question.
I have. I was listening to your talk quite intensively. So I think that I find it very interesting that you even found effects of antidepressants, which are clearly, you know, actually showing an advantage looking at cognitive dysfunction. On the other hand, I was wondering whether you would, if you actually add on or sort of combine different methods, whether you can reach either different groups or you can have an additional effect. Maybe you can comment on that when you add psychotherapy or cognitive remediation to antidepressants.
Yeah, a very good question, Peter. And again, you know, I wish we had clear answers. When I was talking about the differences between antidepressants, of course, those are in studies where we just take an undifferentiated group of people with depression. So they're not actually studies, you know, where we start with people who have cognitive dysfunction. And I think that's really the next step, right? Is looking at, you know, can we identify people with cognitive dysfunction? You know, are the treatments, you know, specific, right, for those people, right? We need to develop those treatments that target some of these, you know, what I call transdiagnostic clinical dimensions like cognition. So it's not surprising that some of the same treatments work for schizophrenia and for depression, right? It's cognitive changes. And so I think that's where cognitive remediation, you know, may be very helpful, but perhaps only if we look at the sample who start with cognitive dysfunction. So I think that's where we need to go with our studies, is to take that group of people, not just an undifferentiated group of people who you know, have cognitive complaints.
As a simple clinician, I would have a second question. My question would be, I mean, what is your way of actually tackling if a patient with depression, because usually we regard patients with depression not having cognitive deficits. We were wrong on that for over 100 years. Often my impression is that a lot of clinicians, they don't even think about this. So what would be one of your key questions to ask to make sure that the patient has functionally relevant cognitive dysfunction?
Yeah, I think the important thing, you know, I think is really executive functioning, because, you know, I think many clinicians recognize that, you know, concentration is impaired, and sometimes they assume it's just concentration and attention because they're so depressed. And so once their depression improves, then their concentration and attention will improve. Whereas it's quite clear now that they also have problems with memory, but it's executive functioning that's so important for our everyday functioning. So asking about, you know, do you have trouble, you know, organizing things, or with multitasking, or with, with making decisions. I think those are the types of things that are more related to everyday functioning. And once you start recognizing that those are problems, then you start to realize it's not just concentration and attention that's impaired in people with depression.
But what would you say? What would you ask? I mean, to concentrate is mean you're looking at the attention span, right? But I mean, what would you? I mean, looking at executive function, what would you ask?
Well, things like making decisions in terms of things like what to buy at the grocery store. Mm-hmm. How often is that not just that you can't remember what you're going to buy, but making those decisions. At work, being able to do more than one task at a time, or shifting your attention from one task to another. I think those are the sorts of things that can be done. But of course, that's where the utility of using a simple scale is helpful, right? Because then it gives you a standardized way of assessing those kinds of cognitive complaints.
Thank you.
So, Peter,
I'm sorry, but I think my slides didn't get or got lost sharing or something. So I will provide you the PDF of the slides if you want to send them out to people.
We don't have such a mechanism, but if you would like to upload the slides in the WPA web page, I think you are more than welcome for this. So, Peter, it's your turn to introduce Peter Falkai.
It's really a great honor for me, a great privilege to introduce Professor Peter Falkai, who is the president of the European Psychiatric Association and who is the chief of the very, very world-famous clinic in Munich, the Maximilian University, and the clinic which is led sometimes by names like Emil Kraepelin, like Hans Hippius, whom I worked with some years, and I'm very proud. I'm very proud that I was closely associated in my time when I worked with the World Health Organization. With this clinic, I visited a number of times. I understand that it was the real mecca for the European and the world psychiatrists. And Professor Falkai, I would like to say some words, not about his 800th publication, and he's very well known in different parts of his career by his work, but I would like to talk about his as a person who is really helped tremendously to the World Psychiatric Association, in particular to the people who need some help and assistance. And that just one side, we tried to translate the book of the Anthology of German Psychiatry into Russian. We tried to do it for 5 years because it was very difficult to obtain the original language, original text in German. Sometimes it was in the old German typing, which is quite difficult to find out, to translate, to adopt to today's condition. Professor Falkai, resolved our problem in 2 weeks. And I'm very proud to report that practically all anthology is translated into Russian. And I'm sure that next year, the whole Russian psychiatry receive the whole text of the original text from the classic of German psychiatry. I think it's a real gest, which we appreciate very much. And you should know about it because it's a sign of the international spirit and to help to psychiatrists in different parts of the world. So sorry to be so long and so emotional, but for me, it's a real honor to introduce Professor Falkai, please. And so topic, guidelines-based treatment of schizophrenia, which is essential and very interesting, please.
Peter, thank you very much for this very kind introduction. I have to say that I mean, to say the full truth, I mean, I received a very good vodka in return, which I enjoyed drinking with my friends. So that is the whole story. So it is a friendship which is based on helping where we can. And I think that's a nice way. So dear Peter, dear Costas, dear Raymond, thank you very much. First of all, for inviting me and for giving me the possibility to give this talk. So I will share my slides. And so, dear colleagues, it is interesting that when you listened to Raymond's talk about cognitive dysfunction depression, that I will focus on negative symptoms and cognition as well, but on another disorder. So obviously it is something which sort of interests us clinicians a lot. So these are just my conflicts of interest, you should know, but I don't think that they are of any interest because I'm not focusing on any specific medication. But what will I speak about? I'd like to give you a whole view on that. So I'd like to start with schizophrenia and its prodromal states, then go to the first episode, multi-episode, and then focus on negative symptoms. And here specifically, what can we do with pharmacotherapy? But we shouldn't forget, and this is something I've asked Raymond about, adding other things like psychotherapy or cognitive remediation. And interesting, there are little things looking at lifestyle modifications or interventions like diet and exercise. And then have a final thought about treatment-resistant schizophrenia. So what is this prodromal schizophrenia? Well, I think there are different phases when we actually look for preventing psychosis, and we usually tend to forget this because, I mean, there are means of primary prevention. I don't want to allude on that, but I mean, in the previous talk, we had trauma. We had we might have the question of obstructive complications and things like that. And actually, if we go into primary prevention, there are a lot of things we can do in order to prevent the development of mental illness. And if you think about cannabis and related issues, I mean, that's the thing where primary prevention comes in. But what can we do? So once we actually have people at an increased risk of developing psychoses, what do we see? Well, we see a decline of global functioning. Often we see affective symptoms and basic symptoms. Well, basic symptoms basically are a mixture of negative symptoms, but which are actually regarded by the patients themselves as the problem. So what can you do? And so a bit looking at the guidelines, which are scarce. We had some hope with fish oil for a while, and I show you a good, well-controlled study on that. Antidepressants obviously don't. Antipsychotics don't work in the way. It is interesting if we look at non-pharmacological interventions, CBT is the way to go. And I think there is some evidence if we combine CBT and antidepressants. Now, this is a large-scale study by McGorris, who actually, and I have to say, a big believer, and I say it would be lovely just to give fish oil to the patients at an early stage of psychosis. But as you can see, placebo and the fish oil, there was no difference. And it's a large-scale study. So we could say, at least for this phase of psychosis, it's very unlikely that fish oil in its own will give us a good remedy. But what else do we do? So if we look, and I like this paper, and it's older, by Fusa Polly, just, you know, what do we do with patients? So focused interventions offered to subjects at high clinical risk, because usually people are a bit, you know, what should I do? So what do they do? Okay, if you look at, so nothing, we don't know, but CBT, obviously, the way to go for a third of the patients. Then CBT combined with antipsychotics, CBT with antidepressants, and the combination of all of that. And usually that is the answer, that if we don't know exactly what to do, we combine everything with everything. But the question is, what does really help? And so they looked at the literature and did a Cox regression analysis showing the association of each group of focused intervention with primary outcome. So primary outcome is not only reducing, let's say, the symptomatology, but improving functioning. And as you can see, here is overall transition days. That means that people then got worse and developed psychoses. And you can see here is CBT plus antidepressants. Here's a combination, CBT only and CBT and antipsychotics. So obviously, and it's quite interesting, that the best outcome you have is CBT and antipsychotics. Sorry, that's the worst one. So the best is CBT and antidepressants. So in a way, it's interesting that also we have this kind of impulse by saying, look, it is a psychotic illness. Obviously, it is not a good idea to actually add an antipsychotic very early on. So I would say, yes, if you have a patient at this stage of the illness and you don't have the possibility of giving CBT, then give an antidepressant only. It's even better than combining CBT and antipsychotic. Once you really have psychotic symptoms, that is not a question. But overall, I would say best would be CBT and antidepressant. If there is no CBT available, even psychoeducation is a good mean. So I would then add cognitive remedy, psychoeducation and an antidepressant. So we started with primary prevention, then went to secondary prevention, and then go, once we really have psychotic symptoms like short episodes of positive symptoms, acute psychotic symptoms, or prodromal negative symptoms, what can we do there? Well, that is no question. At that stage, once you have definitive psychotic symptoms, you should add an antipsychotic. And I personally like to add that also because of the long-term outcome. I would think about even putting the patients on a long-acting antipsychotic. Why? Because if you keep a stable level of an antipsychotic, the likeliness that the patient won't relapse, we know that from several studies, is much more reduced than if you give oral antipsychotic, and then patients might discontinue because, you know, of the illness and so forth, and then you have a course which is more unfavorable. What we don't know about adding antidepressants, I usually thought for a long time lithium and anticonvulsants are good, but obviously antipsychotics, there is evidence for that. If we look at non-pharmacological interventions, CBT is obviously helpful. Well, I think that exercise is coming, at least studies we are currently doing, hopefully give some results, giving a clear direction. And then combining CBT and antipsychotics, that not clear from the literature so far. But I think you don't do anything wrong if you combine it in an individual patients, but you should make sure that you give an antipsychotic. So once you have psychotic symptoms, actually use a medication there. And then we go from primary, secondary, we go to tertiary preventions that actually sort of preventing that the development of the illness is getting worse. So it goes into a stage of residual symptoms where you have negative symptoms and cognitive dysfunction. And there is no questions. We give antipsychotics. Certainly there is a good evidence for individual psychotherapy, for family interventions, and for exercise. What about combination treatments? And I think there are some interesting studies like the RACE study where they combined individual family-based and antipsychotic and supported employment, and it shows a better functional outcome. Therefore, I think once you reach a clear phase of psychotic illness, you should actually try to combine different ways which work. Not only antipsychotics, whatever is possible for psychotherapy and supported employment. There's good evidence for antipsychotic and CBT, and there is, I think at the moment, limited, but hopefully by mid of next year, we have a 5-center study large enough to tell you whether that actually gives a clear effect on cognition. Further issues to look at are somatic comorbidities, psychiatric comorbidities, and partial and non-remission. And I think this is very important. I think we should have the goal of recovery. So the concept of recovery, which it took a while to be accepted within psychiatry, I think it's important, because what does it mean? It means that as a patient, you will cope with your illness, even if you have residual symptoms. And I think that's a much easier concept than full remission or just that improvement of symptoms. So it's a combination of the expectancy of the patient on one side and what we can really reach with our means, including pharmaco and psychotherapy. So that was prodromal psychosis. It's just, I think that, you know, the more we look into the beginning of psychosis, it's important that we actually try to treat the different stages of that. So what about first episode schizophrenia? Well, I'm just quoting out of the German guideline on schizophrenia, which was published end of 2019. So currently summarizes the literature quite well. Well, it is nothing to think about. We recommend offering pharmacological treatment with an antipsychotic as a monotherapy with the goal to reduce psychotic symptoms. And this is an A recommendation. That means also there is a lot of discussion about the use of antipsychotics. I don't think that in first episode psychosis, you should discuss it. You should actually offer it to the patient and hopefully he takes that. So during the acute phase, we recommend reviewing and documenting the psychopathological findings at appropriate intervals. Also, I think this is good clinical practice. I think it's important just to nail down. I mean, that was something which I asked Gray. I mean, what is the question and how can you actually pinpoint down whether your patients gets better? And I usually have simple questions like, you know, what would you say your psychotic symptoms are? If they're really severe, they are 10. If there's nothing, it's 0. So where are you? And then you just document that. From week to week, you see the patient. So this is acute phase. What about first episode? Again, in first episode schizophrenia, recommend offering antipsychotic. It's A, and depending on the psychopathology, treatment setting, and patient references, may consider waiting a few days. Well, that's another discussion is, should you immediately treat the patient or should you wait for a few days? Well, I would say that in the current situation and the critical discussion we had about starting with antipsychotic, it's fine. If you're not sure about the diagnosis, you should wait. But if you are sure about the diagnosis, you should start away. Now, if we actually go for response or recovery, I think it's important that you actually define that, and we have nailed down that the response status should be defined after 2 weeks, latest after 4 weeks by using suitable scales. Even a CGI is fine, and you know, it gives you a clear signal. And in the case of lack of response, despite adequate dosing and after excluding secondary causes, we recommend offering the patient a switch to an antipsychotic, which is different receptor profile. So obviously you start with an antipsychotic and you document if it works. And if it doesn't work, then change to one with a different receptor profile. So if you summarize that, what do you actually do in first diagnosis of schizophrenia? Watchful waiting until the diagnosis is established. I mean, something we clinicians do anyway. Begin antipsychotic monotherapy. Again, I mean, we could discuss that later on once people like to do that, whether we should stay with monotherapy, at least if you look at the literature. That has nothing to do with daily clinical practice. Monotherapy should be regarded first choice, and then specific CBT added. And for that, evidence is A. So after response 2 to 4 weeks, rather 2 than 4 weeks. So there's good data suggesting that is actually 2 weeks when you can decide to change medication. Response status should be determined response, no use, relapse prevention, and then that question is how to continue. And if you have a non-response, switch to an antipsychotic. But it's interesting. I think that, you know, make a decision here. We have a clinical decision, switch to an antipsychotic. It's between A and a, let's say, clinical decision. So overall, I would say there is a clear way of starting with an antipsychotic once the diagnosis is installed at CBT, and after 2 weeks, actually decide how to pursue from here. So this is first step. So we started with prodromal psychoses. And I think, again, there are certain phases to look at preventive measures, starting with just waiting until, you know, really adding an antipsychotic once you approach towards the first episode. We spoke about first episode psychosis. I think there is no question we should start once a diagnosis is actually established with antipsychotics at CBT, and then look at the sort of further things to be done. So what about multi-episode schizophrenia? So I mean, first of all, I think we need to prevent the first relapse. How can we do that? I think even if this is under discussion, and I don't show data for that here, I think long-acting antipsychotics is the easiest way to actually prevent, even in first episode, the next relapse. But once we have relapses, what do we actually do? Well, I would say it's important to actually, again, look for relapse prevention and early warning signs. That's a good strategy to actually prevent the next relapse. But overall, how do we treat recurrent episodes? Well, after an individual risk-benefit evaluation has been performed, we recommend offering people with schizophrenia first episode and multi-episode antipsychotic treatment for relapse prevention. That's an A. Okay. So again, for relapse prevention, we recommend offering the antipsychotics that has already resulted in a good treatment response, which is an A. So that's no question. When choosing the antipsychotic for relapse prevention, we recommend considering the service user's preferences and previous experiences, as well as the different risk of side effects such as tardive dyskinesia and so forth. For that, there is no good evidence. This is good clinical practice. And it just shows you that there is now a discussion which goes away from, let's say, the pure evidence, and then includes the patient's perspective and the relative's perspectives, which is good. But it needs to be made clear that there is good evidence. And I think that in the core, we should actually follow the evidence. Okay, so you could say, fine, so we can treat, let's say, prodromal psychosis, we can treat first episode schizophrenia and multi-episode schizophrenia. Where's the problem here? Well, the problem is that there are, let's say, about half of the patients showing a acceptable outcome, as you can see. So schizophrenia is comparable to bipolar disorder and major depression. And you can see that after an episode or between the relapses, as outlined in these first 2 lines, you could see that there are no residual symptoms. So the patients, once they are not acutely ill, they are in a good functional condition. But what about the other half of the patients? And that's the problem, that in between the episodes, you either have, let's say, remaining residual symptoms, which are negative symptoms and cognitive dissonance, or even worse, it's an increase over time, and that's a substantial number of patients. And this is where the problem starts. The problem actually starts that if we actually look at what is the percentage of people who then reach recovery in schizophrenia, it's still 1/5 of the patients and even less. And that's true for the last 100 years. So actually introducing antipsychotics has helped a lot, but still there seem to be that residual symptoms reduce the likeliness for a full functional outcome. Now, what is the basis of that for this impaired outcome? Well, these are residual treatment refractory symptoms, especially cognitive dysfunction and negative symptoms. And the question is, what on earth can we do there? So what can we actually do in order to improve, especially cognitive dysfunction? Well, this is an overview which I sort of modified according to Phil Harvey's slide. So actually, if you look at what mechanisms has been actually tested in order to improve cognitive impairment, well, we know nicotinic antagonist, adrenergic agonist, modafinil, amphetamine, cholinesterase inhibitors. I remember the studies and I thought, oh, this would be neat, right? Also, you have a cholinergic deficit, so you could improve on that. They failed. Empekines, then we had the whole sort of glycosarin, D-sarin, and so forth, failed. Histamine receptor antagonists, pregnenolone, GABA antagonists, and PDE inhibitors. So I think there is a long range of studies trying to improve that. And I think there is one, interesting combine, which is now in phase 3. It's a glycine transporter A inhibitor. Why? What is so special about this? Well, we know that schizophrenia is said to have a NMDA receptor hyperfunction. And NMDA receptor function is fundamental for cognition. So glycine is an essential co-activator of the NMDA receptor. So if you inhibit the glycine 2 transporters, increases glycine concentration in the synaptic graph, and that leads to a normalization of NMDAR receptors. So that's the theory behind it. And the question is, does it work? Well, let's say in phase 2, that was published, first author Wolfgang Fleischhacker just recently. And what did they show? Well, they actually could show that if you look at the different dosages of this compound, 2 milligram, 5 milligram, 10 milligram, 25 milligrams, you can see there is one, it's the 10 milligram dose, the green one, which actually shows, including into the study, 6 weeks, 12 weeks, you can see a quite significant improvement of cognitive dysfunction. So in phase 3, and we are currently including patients in this trial, we want to see, it's a large-scale study, whether this compound is really helpful to reduce, well, I wouldn't say dissolve, but hopefully reduce cognitive dysfunction in schizophrenia. But the question is that all we can do? I mean, I've shown you that we've tried a lot of things and actually tackle this issue. So the question is there anything else we can do beside pharmacotherapy? Because I mean, waiting for the study to be finished and things like that, until then, the question is, what will we do? Well, and the question is that we actually know that psychotherapy seems to do something, especially if you take a very severe group, the so-called treatment-resistant schizophrenia group. And CBT works. Interestingly, we have to say, even in treatment-resistant schizophrenia, more in positives than in negative symptoms. But are there other things you can do and your patients do anyway? And it's interesting that there are now meditation-based mind-body therapies for negative symptoms. Well, usually psychiatrists would say, what a nonsense. Well, it is not. Because if you actually look at 3 of those, yoga, Tai Chi, and mindfulness, you find quite specific effects on negative symptoms. So usually, once I've read this study, I thought, well, just ask our patients whether they do yoga, and it's good. So it's improving the negative symptoms. Tai Chi, not so much, and mindfulness does. So actually, the mindfulness we introduce in our 3rd and 4th wave of psychotherapy might work on negative symptoms. It's interesting that positive symptoms, again, is another story. So yoga works, but Tai Chi doesn't work and mindfulness doesn't work. Well, if you think about it, it makes sense that you find this differentiation. So overall, I would say yes. So if your patients like to do Tai Chi or yoga or mindfulness, support them. That will improve the negative symptoms. What about cognitive remediation? This is always thought to be one of those things which work, but we don't know. Well, actually, it does work well in psychosis. And the question is really, does it work in negative symptoms? And this is a quite nice study published in 2019, where they looked at the different domains of the SANS scale. So the experimental symptoms were consisted of avolition, apathy, and anhedonia and asociality. So it's the 4 of the 5 A's. So obviously there was negative symptoms, and expressive symptoms is affective flattening, blunted affect, and alogia. So if we actually look at experimental, right, you can see that cognitive remediation really works combined to the, let's say, control condition. And then we look at the expressive, again, we have the same. But there is something else which I wanted to allude to you. We actually look at the SANS apathy scale, and we compare those patients who take oral antipsychotics compared to those who get injectable ones, that this effect is more clearly in the group of the patients receiving injectable antipsychotics. So indeed, as pointed out previously, in the early stages of psychosis, even prodromal ones, but certainly at the first episode, we should make sure that our patients receive the best possible antipsychotic coverage, which is actually based on the long-acting antipsychotics. What about lifestyle interventions and negative symptoms? Well, you will say, what is this? I mean, you know, we give medication, we do psychotherapy. Why do we actually need to change the lifestyle of our patients with schizophrenia? Well, this is, I think, a very nice paper by the Lancet Commission, led by Joe Firth. And let's look here. Here we have the different illnesses, which is major depression, bipolar disorder, and schizophrenia. And they looked at alcohol, tobacco use, physical activity, sedentary behavior, poor diet, and poor sleep. And I just like to focus on two. One is look at physical activity and sedentary behavior. So patients with schizophrenia, the majority of patients do not meet physical activity guidelines, whatever that means, but patients are sedentary for about 11 hours per day. So there's not a lot left actually to be active, right? And in addition, if you look at the diet, patients actually consume around 400 calories more than the general population per day. Well, it's like a whole chocolate bar you eat. This is like 400 calories. So you do that every day on a day-to-day basis. So actually, can we see that in their diet? Yes, we can. So we actually look by different patients, unipolar depression, bipolar disorder, and schizophrenia. And you can see, especially in patients with schizophrenia, if we actually look at the fats, there is a significant intake compared to healthy people. What about carbohydrates? Again, we have a significant increase. So we have a problem here. So beside the illness, I think that the illness and the negative symptoms actually lead to this unhealthy lifestyle. We know that. But what can we do about this? Well, I think it's important to actually open this to the patient. Tell him that, there is overweight. We shouldn't forget about the antipsychotics. There is certainly too much sedentary. And so both of these, so diet and sedentary, should be pursued. We can't change it immediately, but this is a long-term endeavor. And for that, we need to actually include the carers in this cycle. And we actually need to include ourselves. what should be done? Well, I usually show the STRIDE study. Why? Because people with quite a significant BMI were included. So those ones who really needed some treatment. And what is the basis of that? And that is possibly easier than one thinks. It's obviously not enough to actually tell people to do that, but you need to look at different things. And diet, usually say an apple a day, for instance, physical activity, 15 minutes a day of brisk walking, and sleep. So not too much, but sleep regularly. So these are three things which need to come together. What happens if you actually people go into such a treatment program? Well, the weight loss they have is not enormous, like 3 kilograms. So you could say, what should we bother about this? Well, we should, because actually, as you can see, all the other parameters improve. So it's the lipids, it's glucose, and it's blood pressure, and so forth. Why is this important? Well, it's important because we know that people with schizophrenia, bipolar disorder, and depression, but especially with schizophrenia, have reduced life expectancy by roughly 10 years. And you could say it's suicidality, sure, it's medication, sure, but all of that leads to a certain lifestyle, and that leads again to a somatic problem. And actually, if you want to tackle that, you need to have a long-term idea of what to do. Now, you could say, fine, but what about? So diet, I said, just watch it and, you know, make a point that it would be good that people actually watch their diet. So what about exercise? Well, a lot of people don't like this part of the talk because they say it's, you know, too much strength. But does physical exercise help in negative symptoms? And here we have a meta-analysis, a recent one, as you can see, ending up with 17 controlled studies, which actually give us an answer. And here is the answer for that. If we actually look at aerobic exercise, including one of our first studies there, you can see overall you have a significant effect on negative symptoms. Well, you can see there is an overlay. So you have studies which show a clear-cut effect as here, but you see studies which are not significant. What does it mean? Well, it means that overall exercise, like all these measures, don't tackle 100% of the patients. You will actually, it will meet about 50% of that. But still, an easy message is required. Easy message means 50 minutes a day of brisk walking 5 times a week is enough to actually change your physical health. So it's not a lot. So aerobic exercise, that means not putting the strength too much. So if you look at non-aerobic exercise, that's not that effective. So overall, keeping within the aerobic zone, that's fine. So overall, diet and exercise is fine too. And if you look at the distribution of the studies, looking at the funnel plots, that's fine too. But how does it work and what is it? And this is one of our studies which we performed, waiting now for exercise 3. This is exercise 2. What did we do? We have asked patients with multi-episode schizophrenia to do indoor cycling 3 times a week, 30 minutes. And we compared them with healthy people who actually then did on indoor cycling. And the interesting thing is, because we thought that not only exercise in itself, but we should give that a cognitive stimulus in addition, because exercise stresses the brain. And if you want to have a functional improvement, you need to give a stimulus to the brain, some cognitive food. So what we did, we added after 6 weeks cognitive remediation in the schizophrenia group. In the healthy people we had, again, after 6 weeks, we added cognitive remediation, and we had a control group of patients with schizophrenia. And after 6 weeks doing table football, they received cognitive remediation. And the hypothesis was clearly that in the first arm, where you combined exercise with cognitive remediation would have the best functional outcome. And as you can see, here we had endurance training and cognitive remediation. We entered the study. This is after 6 weeks. This is after 3 months. And we look at global functioning, a very simple measure. We look at social adjustment and we look for cognition. And you can see that there is a significant improvement in global functioning and an improvement in social adjustment if you look at household, leisure, and overall. And if you actually look at the table soccer groups, so those guys who actually moved, but not their big muscle groups, you can see actually there was no change. So obviously exercise plus cognitive remediation makes this a change, because as you can see, there is some effect of cognition because people entered cognitive remediation. So overall, I think it's important, again, as we discussed several times, to combine. So have sufficient antipsychotic treatment, have psychotherapy. And if you think about lifestyle modification, I would say add exercise, for instance, to cognitive remediation. And if you like to read a nice paper, which just came out by Galderisi, by Silvana, and they, looked at everything, how to measure negative symptoms. That's the first paper. And the second paper they published is on what are the means you can treat with. And actually they included exercise can be considered for persons suffering from negative symptoms as part of an integrated treatment plan, also aiming at improving physical health. They gave it only a C. So we need to add better data to go up to B and A. So just a few words to treatment-resistant schizophrenia, because we started with prodromal, first episode, multi-episode. And I always say we shouldn't forget those people who have the worst outcome. And there is a percentage of patients having that. So if there is no treatment response, which suggests not to increase antipsychotic doses above the approved range, that's an important thing, but actually change to an antipsychotic we call clozapine. So I think my plea would be, once you tried several antipsychotics, and that's my final slide there, you start with an antipsychotic in monotherapy, that's fine. After 2 weeks, you change to an antipsychotic again in monotherapy, no change, then you change to clozapine. So I think it's important that you keep that. And if that is not working, you have combinations and ECT. But I think it's important to outline, usually people then combine in the beginning. So I would really recommend rather change to an antipsychotic with a different profile and then go to clozapine in the next step. So I'd like, as one of my last few slides, I think I have 2 more, this one and one another one. I like the staging model. There are several staging models around, but I like the one by Pat McGorry, who then starts and saying, people with an increased risk of psychosis. So what should we do here? And here you can see the fatty acids and especially the fish oil. And then what about the next phase where you have ultra high risk? Again, you can see here just psychoeducation, and as we said, rather than antidepressant, and they added an atypical antipsychotic. First episode, immediately you will say, well, we want antipsychotic, and then incomplete remission, recurrence of relapse, you have all the things we discussed, and at the end, clozapine. And I think it shows you that we have to look at what stages are the patients and at what phase of the illness they are. So this is the summary and the conclusion. For me, no question. I mean, looking at the treatment of people with schizophrenia, we need to aim at recovery, which clearly is the goal, that people can actually cope with their symptoms. This implies treating psychotic symptoms, but also all other aspects of the disorder that have an impact on people's real life needs, work skills, interpersonal relationships, everyday life activities. which is often forgotten. So once they have no positive symptoms, that's fine. It's not enough. To be treated are therefore negative symptoms, cognitive dysfunction, improve resilience, and reduce internalized stigma. So the treatment provision should be tailored to the needs of the patient and the stage of the disorder. So with having said that, I thank you for your attention, and I'm happy to take questions if there are any. And as you can see, this is a final slide. This gentleman here is actually Alois Alzheimer, who was one of the first describing neuropathological changes in the brains of people. At that stage, they're called dementia precortex, later on schizophrenia. And here you find a lot of fine scientists, which then visited Munich. Look about Louis, the Louis body Louis, and Perusini or Zaletti, and many others. With having said that, thank you very much. And I'm closing my talk. So, no question.
Peter, it's your guest. You need to mute.
Well, first of all, thank you very much for such a comprehensive approach to the principle of treatment of schizophrenia, very contemporary one, give the whole overview of different points of view. Of course, I have a number of questions because I understand more or less your, clinical language, but at the same time, knowing the tradition of the German psychiatry, I would like to ask you 2-3 things. Some times ago, I made the analysis of comparative assessment of utilization of long-acting neuroleptics around the world in different parts. We compare, for instance, US with utilization in China, in Japan, in Germany, particularly in Spain, and in Russia. And in fact, the conclusion was not so positive because it's quite evident, according to the different data, that they have a quite positive results. But at the same time, utilization of this drug is not very large one and not very progressing. And of course, somebody said that it is because of the prices. There are some different points of view, but what is your attitude? What is your opinion to this type of treatment of schizophrenia?
So you mean using a long-acting antipsychotics?
Yes. Yeah, purely. Yeah.
Well, I should have put in the data there, but I'm always impressed if you look at the longitudinal data by the Finnish group of Tihonen, who looked longitudinally for 7 years and looked what happens to people discontinuing at year 1 to year 7.
Yeah.
And even at year 7, you had a increased rate of relapses. So, my conclusion from that is that indeed, with the exception of the 20% of the usual people with schizophrenia, where we have one episode and then we don't have any episodes anymore, I think it is an illness which goes along with a high risk of relapses. Mm-hmm. And if we want to avoid this, I personally think, I always say, if my son, he's now 25, would develop psychosis, I would try to convince him, at least for the first 2 years, to take a depot medication. Why? Because we know from measurements in the blood that the level is much more steady than if you give oral, because then you have these little sort of bumps. That's one thing. The other thing is, treating even patients with multi-episode and severe schizophrenia, I try to convince and put them on a depot antipsychotic. Why? If you look at the PET data, you see that in once you have schizophrenia, the dopamine system is more labile, especially you have environmental stressors. So the best protection is low dose antipsychotic. And I personally think that, you know, take a depot, possibly add some clozapine is my way to treating severe psychotic illness. And yeah, we need more studies for that, as you say, Peter, because there are different experiences in different countries. But I would read the literature at the moment that the best antipsychotic treatment you can give to a patient in the early phases of psychosis and later on is long-acting.
I see. I see. Well, of course, I have some other question, but there are a number of questions from the audience, and I'm not abuse my position. So let's start. First question, is physical activity associated with reduction in inflammation in schizophrenia?
Yeah. In the beginning, after, so the activity is just finished, it will go up, but then it will be reduced. So if you actually do that, as I said, 15 minutes per day, included in your daily activity, it will actually not only improve your physical health, it reduces inflammation, and it improves negative symptoms and cognition.
I see. Thank you. Next question. Should we start clozapine earlier according to the optimized study?
Yes.
Yes.
I think that I personally would say if you have a complete non-response, for instance, after a first attempt, I would, you know, if I would be allowed, I would put people on clozapine. But I would say, you know, you should actually treat every patient with schizophrenia who is not responding once in their life with clozapine. And often that is not regarded. I don't know why people are so anxious to use clozapine, but I think it's still the best option. And you spoke about Hans Hippius, who did a lot in order to induce clozapine, not only in Germany, but worldwide.
And what treatment do you recommend if clozapine and ECT fail to treat schizophrenia resistant?
Very good question. Yes. Well, what I do is I do discontinue all medication. So we do a drug holidays. Sometimes these patients don't get worse, but they have less side effects. If that is not working and they get more psychotic, I put them on a depot, so long-acting, in order to reduce the psychotic intensity. And to be honest, I give them some clozapine in the evening between 75 and 150 milligrams. That doesn't work always, but it works. And another little tip I give, if they have some effective component, I put them on a depot and then I add lithium. Because once they have an effective component, you can actually, like an augmentive possibility, add to the effect of the antipsychotic. So this is what I usually try. It doesn't work out always, but I'm surprised how often it works fine.
I see. Well, some say that relapse after discontinuation is actually withdrawal of supersensitivity psychosis. What's your opinion?
Well, good point. Yeah, I would say that there are arguments for that. So yes, agree.
Okay, and well, last question from my list is from Russia. Finally, Dr. Smirnov asked, "What's about different protocols of TMS itself, as well as in combination with psychotherapy and physical treatment in relation to improvement in cognition, negative symptom in schizophrenia?"
So the question is about TMS. It's an important question. I mean, if you look at meta-analysis, they seem to show a clear effect of negative symptoms in schizophrenia. If you actually look at the biggest so far controlled studies, which Alkamid Hassan from our department did, and which was published in Biological Psychiatry, that study, 2 arms, 73 per arm, so actually intervention compared to placebo, RTMS was completely negative. So it was so negative that people would say this is out. But the interesting thing is, if you then look into the data, you can actually see that roughly 40 to 50% of the patients responded. And if you actually looked at those ones, they responded quite well. So my reading of that paper is you should actually use RTMS in patients with negative symptoms and with negative symptoms. But if it doesn't work, after 3 weeks, discontinue. But if it works, it's a very good and fine possibility to treat.
Mm-hmm. Well, thank you. There are no questions. Well, so I profit to have the last one, very particular, very probably naive. You know, in my country, there are the people still using the term proposed by Eugen Bleuler in this 4 sign of schizophrenia, autism. And because autism was eliminated from the old classification and goes to child psychiatry, and now it's disappeared and so on and so on. But the latest, some investigation, Baron Cohen and one Russian psychologist, quite famous, Dr. Kolmogorova, they show that the main association, or the main correlation are between social impairment and autism itself, and not to, for instance, cognitive impairment. And probably it's too premature to eliminate from the negative symptoms this classical term of Bleuler. Well, what is your opinion about it? Of course, I understand we cannot go outside of the today's classification, but this is a reality of the research data.
Well, I would say I like the concept of autism. The problem is, you see, that I mean, if you look at childhood autism, but adult, or let's say, adult autism, which we have actually now, we have autistic spectrum disorder. I think that was an important move in order to show that this is a distinct entity. With that, we have lost the autism in schizophrenia, which I think is a pity. So I do get your point that we should have kept it, but well, we've lost it due to a bit fine graining, which I think is good, fine graining of diagnostic possibilities. So finding actually a new component, and possibly with that, or new disease entity, which we can actually treat differently. But I do get your point that there are autistic features which we need to take in account in schizophrenia as well. Well,
thank you very much. They are, well, now we finished. You suffer a lot from it's too premature. Give me the floor, because otherwise we will kill you with the number of questions. Well, thank you very much.
I want to make a question, last question. I have the privilege. I have the privilege of the last question, right? Okay, Peter, I would, since this is a Meet the Expert series, I would like to step out of the specific topic of your speech and ask you a very general and very radical question. In your opinion, what is schizophrenia? Because a lot of mental disorders have hallucinations. A lot of mental disorders have depression-like symptoms. A lot of mental disorders have whatever symptoms you can find in schizophrenia. What is schizophrenia in your opinion? What makes schizophrenia to differ from other mental disorders and constitute some kind of entity, a unique or an umbrella, whatever group of disorders, or a single disorder, whatever this is? In your opinion, what is this thing? As a general idea, I mean, not evidence-based, as your general experience says.
Well, I would say it's a very good question. I mean, what is different? What is in this entity different from, for instance, let's say drug-induced psychosis or other organically sort of induced hallucination and things like that? Well, I think that for the majority of people with schizophrenia, you have a continuous course where you actually reduce your vulnerability or your ability to cope with normal stressors. And in addition to that, which then leads to psychotic symptoms, you have an increase or at least a steady amount of cognitive dysfunction and negative symptoms. I think this is something you don't have in other disorders. I mean, you have it in an attenuated form in bipolar disorder or in depression, but I would say it's a step. And if you look at the biggest step of cognitive dysfunction and negative symptoms, that's in schizophrenia, followed by bipolar disorder and then unipolar depression. So my definition of that would, it's a disease entity where you have a relapsing course with a stable or increasing residual symptomatology. This is something I would say you don't have in other disorders. But if you then open up the umbrella and you say, is that the same disorder? I would clearly say no. It's different entities. And if you ask me at my research, I would say there is a plasticity subtype. So there is a subtype where you, for instance, do exercise, cognitive remediation, what so forth, or TMS, which clearly gives you improvement, and you have another subgroup where that doesn't work. So it's the non-plasticity, possibly the inflammatory subtype. Well, I would say we would need different ways to treat this. So I think, yes, there are common clinical features, but under this umbrella of a common clinical picture, I think there are at least two big chunks. I would rather say even three. So two, I said, one is plasticity and the other one is non-plasticity, rather inflammatory subtype.
Interesting. Well, thank you very much. Well, I really, well, you know, you give the idea for further question, for further discussion. I think, Dr. Falkai, I think I'm absolutely sure that we will invite you for another webinars for sure, and to talk about schizophrenia more deeply, because it's still a question which is not, which is an enigma, and it is interesting sometimes to come back and to see how it's developed the story and what is the present situation. It's always discussing, it's always controversial, and it's always give us a new border, a new, how to say, grants, you know, for the discussion. Thank you very much. I think I have no any more question in my list, and I appreciate very much from my side, from the side of WEPA, the participation. Wonderful webinar. I have number of reaction from different part of the world. Thank you very much, Professor Lam. Thank you very much, Professor Falkai. And I greatly appreciate all efforts of Professor Fontolakis, who organized this fantastic webinar. Really great feedback from the audience. And don't forget, it's Sunday evening. The people are really in front of the screens.
Thanks, everyone.
Thank you both for being here with us. Peter, Raymond, thank you for your excellent contribution. For the audience, I would say that we will have the next Meet the Expert in sometime in January. It will be announced soon. Thank you all for being here with us. Take care.
Thank you, Kostas and Peter, for organizing that. And it was very interesting, even if it's Sunday evening. Bye-bye.
Thank you.